I was asked to give an overview about the evidence currently on when to perform interval cytoreductive surgery in advanced epithelial ovarian cancer, and we actually had a very vivid discussion afterwards, just because it is a topic that has changed and evolved over the years. So initially we thought that if we operate later than 3 cycles of neoadjuvant chemotherapy, the patients will have a worse survival. However, what we have realized later was that this was more like a self-fulfilling prophecy. Just the patients who were poorly, who had lower response, had a worse performance status, they used to be operated later. So, of course, they would have a more adverse outcome than the patients who would be operated earlier. Therefore, I have presented a prospective randomized study that was from the Italian group that was actually presented for the first time in ESMO in Rome in February this year, that would, in a prospective randomized design, compared whether patients who are operated after 3 or after 6 cycles of neoadjuvant chemotherapy have a worse outcome. And this was not the case. Interestingly enough, they didn't also have a significantly higher complete resection rates. However, the worse outcome that we perhaps expected to happen was not validated. Patients had no deterioration of OS and PFS. So practically this study showed that it is actually safe to operate even after 6 cycles. What I have, however, emphasized in my talk is that we need to go through the clinical scenarios why we give neoadjuvant chemotherapy. And the timing of the surgery really depends on the resolving of the reason why we gave neoadjuvant chemotherapy. For example, if you have a patient with a very fresh pulmonary embolism or a heart attack or a medical event, of course we need to use the neoadjuvant chemotherapy as overbridging time for this acute event to pass. So we then need to operate after as many cycles as are needed for this acute event to resolve. If it's a patient with very wet disease, ascites, pleural effusion, where even though they have responded after 3 cycles, the ascites is still present, then we might as well give 2 cycles more, add anti-angiogenetic treatment in order to expedite the resolving of this wet disease so that we have a more dry disease. Have shown how much morbid the operations with high volume shifts are in elderly, a bit more multimorbid patients. So it is not, at the end, what really matters is not really just one number, it's a whole clinical scenario and the whole clinical picture, why we're doing what we're doing, and the journey and the timing of the journey really depends on many parameters. What the recent ASCO guidelines say and recommend are that neoadjuvant chemotherapy should be given for 3 cycles, and after 3 cycles we should reassess whether surgery is feasible. However, a degree of flexibility in terms of timing of the surgery is allowed and does not seem to be detrimental on survival.